So we're going to talk about Ards. I'm going to cover Ards ventilation, when we use neuromuscular blocking drugs, the staircase recruitment manoeuvre and decremental peak trial, which is quite a mouthful, and we'll cover that. Is anyone used to that already? No. Prone positioning, not going to cover in a great deal of detail because, as you know, there's the video, the training and everything. Prone positioning, that's what we discussed. ECMO referral, I'm going to mention it briefly, just so you have some idea when we might do that, what might happen. And then I'm going to talk about APRV in case we end up using it a little bit. I haven't substantiated all this stuff with lots and lots of trial data. There's a little bit, but not a lot. But before we move on, I've got a picture of a pressure waveform to remind everyone the plateau pressure is the pressure that the alveoli are exposed to, and it's at the patient end, whereas the peak pressure is what's measured at the ventilator end. And to get the difference, which relates to the resistive pressure, you do an inspiratory hold manoeuvre. So we will talk about plateau pressure a tiny bit, just a refresher.
What does APRV stand for?
Airway pressure release ventilation. That's an example of a good question I know the answer to. Thank you. So very, very pleased we've got the intubation teams. It's fantastic and we're very grateful to everyone for putting it all together and practicing it. So this is starting from when they are intubated and now we're going to ventilate them. So initially you just want to get things looking safe, and I'm not going to be not too fussy. So you're going to start at 100% oxygen. And then in terms of what size breaths you want 6 to 8 mils of ideal body weight. That's the key, not actual body weight. So I weigh 102 kilos, but you should ventilate me as if I weighed 75 kilos. And you're going to use a pressure control mode that's targeting a tidal volume. So you're not using volume control. On the ICU ventilators, it's called VC plus. It's not a great name because it's not volume control, it's pressure control. But you dial up a tidal volume and it gives a breath. It works out what tidal volume it gets for that breath and then it adjusts the pressure appropriately. I think on the anaesthetic machines it's called PRVC. It's called different things on ventilators, but the idea is the same. It's a pressure control that targets a tidal volume, which relates to your ideal body weight. Because you're giving small breaths, you need to give them more frequently. Because someone's got ARDS and you've just intubated them, you want at least 10 of PEEP. I wouldn't go less than 10 initially, but I wouldn't go to town either at the moment. I'll just start with 10 or something, or a bit more if you'd like, if you're struggling. One of the things that I always do is I maximise the mean airway pressure. So the main determinants of oxygenation in any situation, your FiO2 and your mean airway pressure. So typically in ARDS you have quite stiff lungs with poor compliance and rapid emptying. So far for this COVID, I think that the lungs aren't that stiff, but they are just ineffective at oxygenation. But if they were stiff, then you often have a period of time during expiration that they finish breathing out because they've got a quick expiratory time, and then you've got a long time with no flow, nothing happening. That's essentially a waste of time, and so I fill up that time with inspiration. So the longer they have to breathe in, you get your tidal volume for lesser pressure, and you maximise your mean airway pressure. So I always fiddle with the IE ratio. I never leave it 1 to 2. So that's something I would do. Not necessarily initially, but next is what I do. And so once you've just intubated them, you just want the SATs to be safe, and you want the end-tidal CO2 to be safe. You're not going to be too fussy. You're going to get a chest x-ray, get blood gas. And the principles of lung protective ventilation, as we've already just discussed here, is frequent small breaths, some PEEP, and aiming for a plateau pressure of less than 30. Normally people rally in the first hour or so after you've ventilated them. So then, and for the next few hours, you're going to be a bit strict with your tidal volume. You're going to tweak your respiratory rate, and you're going to measure the plateau pressure. And try different PEEP levels. Obviously, your different PEEP levels, you have different amounts of, you have different compliance, and what you can do sometimes crank up the PEEP, you get more compliant lung, and then you can actually lower the plateau pressure despite having a higher PEEP. So you try that around, fiddle the IE ratio. I think we'll probably be quite relaxed about SATs targets, and similarly, you want permissive hypercapnia, so you're going to deliberately let the CO2 be high as long as they're not too acidotic. Is that all? Has anyone got any questions about that? It's all fairly straightforward stuff.
Do you get any rebreathing if you've just got an IE appointed on? Like, do you give them enough time? Is that ensuring they have? So you
can look at the expiratory flow. That's what I haven't added that to the talk yet, but you can examine the flow waveforms and you can see if they finish breathing out. Okay. Yeah. So sometimes you can accept a little bit of gas trapping, which we'll come to next. So the first guy we ventilated with COVID was doing really well, and once the rocks worn off, you don't need to keep them fully mandatory mode, you don't need to keep them fully sedated. It's okay, and it's a good idea to wake them up. We aim for a RASS, or Richmond Agitation Sedation Scale, of -1 or -2, which means when you say their name, they open their eyes to voice to look around the room a bit. That's what we're aiming for. and you can also get into a spontaneous mode of ventilation. So you're reducing the sedation, you're getting into a spontaneous breathing mode, but you're not trying to extubate them. That's just how you want them to be. And we got him, the first chap, into that mode of ventilation quite quickly, and it was really good. That's what you aim to do. The longer you're in a mandatory mode for, the quicker your ventilator, your diaphragm wastes. So if you're in a spontaneous breathing mode, you preserve your diaphragm strength, which will be very important in these people. You try different levels of PEEP and pressure support, and you can just look at their worker breathing, their respiratory rate, and non-invasive things like their Untitled and their SATs. So that's how we get going with the lung flex ventilation. And then I've got a whole series of slides about troubleshooting, and that's what's in. So if there's expiratory flow limitation, like they've got underlying airways disease, so obviously you need to give them long to breathe out. Typically, if they've got pure ARDS, they won't have much of this, but they can have mixed pathologies. They might have some bronchospasm. So if that's a problem, then you need to give them long to breathe out. So you need to give them less frequent, larger breaths, so the opposite of normal Ards style ventilation, but it isn't normally a problem. You can accept a bit of gas trapping, and then you can measure, so you'll see that before they finish breathing out, the next breath comes, and you can see there's a little bit of expiratory flow before the onset of the next breath, or at the onset of the next breath, and you can measure on our ventilators the intrinsic PEEP. And generally, if it's low and it's not causing hemodynamic upset, and they're not getting dynamic progressive breath stacking, you can just ignore it, but only if it's not too much. Often sedation, so for most problems on the ventilator, as you guys know better than I do, sedating people and paralysing them is always very effective, but it's not necessarily the right thing to do in terms of progressing them away from where they started from. In Ards, they've done lots of drug trials. One drug that you should avoid, even if there is expiratory flow limitation, is salbutamol. I mean, you can use it if you really have to, but in the trials, regular use of salbutamol or salmeterol increase mortality, so I would try and avoid bronchodilators or beta agonist bronchodilators, but you can still use ipratropium bromide. If they're breathing too fast, it's super easy. You can use some more remifentanil as long as we've got it, morphine if we haven't. If there's patient ventilator dyssynchrony, so there's lots of different things you can do here. You can try to be clever and adjust the triggering, make it more or less sensitive, and adjust the PEEP so they can overcome their intrinsic PEEP to trigger ventilation. Sometimes you can just ignore it, and that's fine, so live with it. I mean, ugly waveforms isn't bad, particularly if the patient's comfortable and got good gases. Sometimes you can just ignore it. The mode of ventilation on our ventilators, the bi-level mode, is meant to be the most comfortable one for someone who's not that synchronous, so they can breathe in and out independent of what the ventilator's doing. So we often use that mode. Always more sedation is always effective, but ask for help as well if you're not really sure what to do. So the main thing we're going to talk about is what happens if there's refractory hypoxemia. So you've got your patient, they've been intubated, they've got the lung flex ventilation, they're on a high FO2, they're on a high PEEP, and you've not got good gases. What do you do about that? So once you've turned the FID, sedated and paralysed, and there are other things you can do. So how do you guys do recruitment manoeuvres in theatre? There's a range of different ways of doing it, aren't there?
No, the closed AP valve hold back for a bit. There is a inspiratory hold on the ventilators we have in theatre, so you can do that too. And I think that does 40 centimetres of water. I don't know how long, I think it's 30 seconds.
Different ways. I assumed you did it like that, but Matt Dickinson said he did a complicated recruitment manoeuvre, but most people just do that, I think, don't they? So that you can just give an amount of pressure for a period of time. It can cause significant hemodynamic upset. A staircase recruitment manoeuvre is designed to avoid that to some extent by just taking a more progressive approach. And then the decremental PEEP trial is about finding the best PEEP for that patient at that time. Prone positioning, ECMO and APRV, so we'll talk about some of them. Previously, we used to use neuromuscular blocking drugs for the last decade quite freely after a paper came out from France where they had patients with severe Ards and they randomised them to cis-sucrocurium infusion versus not, and they found a really impressive reduction in mortality, an unbelievably good reduction in mortality. So the Americans, the ArdsNet group, which is now called the PETAL group, put together a trial which completed and published last year. Is a 3 times the size trial, and it showed no difference in mortality. So since then, we don't use cis-sucrocurium infusions routinely, but we can give boluses if we're struggling. So that's still reasonable to use as a rescue therapy, but we don't use it as a routine measure. That's all I'm going to say about neuromuscular blockers. So the staircase recruitment manoeuvre, you guys, no one's ever seen this before or done it before. Okay, so the things to tell you is it can take quite a long time. You have to be committed to spend at least half an hour by the patient's bed space fiddling with the ventilator. It can make people a lot better. Equally, it can make people a lot worse. So you have to be prepared to take that gamble. Don't use if they've got pneumothorax or that you think they're high risk of pneumothorax, for example, they've got bullous lung disease. Definitely don't use if they've got RV failure or they've got history of pulmonary hypertension or there's a clinical suspicion of RV failure. What can happen is by increasing the intrathoracic pressure excessively, you can decrease your right ventricular cardiac output, your right ventricular function, then your cardiac output, and then whatever you do in terms of inotropes, fluid, pressors, whatever, they can enter a spiral of decline which you can't reverse. So RV failure, don't do this. It's worth saying that people who believe in this had their enthusiasm significantly tempered by a trial that came out a couple of years ago, where it was called the ART trial, came out in 2017, and it was a randomized control trial on ARDS with this kind of protocol versus not, and there was an increase in mortality in the intervention arm. However, they used much more aggressive levels of pressure than I'm going to recommend today. You can do it daily, but as I said, it takes quite a long time. It's only really possible in mandatory modes, and like I said earlier, we're trying to progress people as quickly as you can to a spontaneous breathing mode. If you're having to paralyse people to do it, then it's probably not worth doing. You're probably doing more harm than good. So the first thing to do is the staircase recruitment manoeuvre. So this is pressure and time. So you make sure the patient is euvolemic, they've got a decent blood pressure, and then you twiddle set the driving pressure to 15, you turn on some alarms, and you put the PEEP at 10, you see there, and then you adjust the FiO2 till they're sat to 92. So it can't be too good, can't be too bad, so sort of a comfortable medium point, and then you just leave them alone for 20 minutes, don't change anything, and then you can start the recruitment manoeuvre. So you need to start from a position of stability, and then you've got your delta P, your driving pressure, 15 centimetres, and you just every couple of minutes you turn the PEEP up from 10 to 15 to 20 to 25. That's all we're going to do here. In the trial they went up to 40. So they had a delta P of 15 over a PEEP of 40, so they had really big driving pressures. In fact, it was 45, so they had airway pressures of 60. You can see how that might cause problems. So we're not going to do that. This still goes up to an airway pressure of 40, but it's much more gentle. The idea is that you decrease the hemodynamic consequences of decreasing the venous return in a staggered sort of way. So once you've done that, and they should tolerate that, obviously if they don't tolerate, stop, and don't recommend anyone else to do a staircase recruitment manoeuvre on that patient. So once you've done that, what you should have done is recruited every available lung unit, and then you set the PEEP to 20, so still quite high, and then you do the work out what's the best PEEP. So it's the decremental PEEP trial. So you start off with your PEEP at 20, like I discussed, you still got your delta P of 15, and you come down, you have to be patient here, because you're going to wait 3 minutes at each PEEP level, and you bring it down in little stages, and at each stage, at the end of your 3 minutes, you write down the patient's SATs and you write down their tidal volume. Because your delta P is constant, your tidal volume represents their compliance. So for the same pressure, you get a different lung volume. And at the end, I'll show you on the next slide, you get a little chart that you've drawn out, and you can work out the best PEEP, and then you re-recruit, so you pop the PEEP back up above that for a couple of minutes, and then you just put it on the best PEEP. So what it'll look like is you're going to make a little, just write on a scrap of paper, PEEP down one column, SATs and tidal volume. You put the PEEP at 20, you wait 3 minutes, write down the SATs. The SATs will be low at a high PEEP level because you'll have alveolar overdistension, so you have lung units that are really high airway pressure, so they're ventilated but they're not perfused. And so you have shunting. You'll also have poorly compliant lung because they're overdistended, so you have a smaller tidal volume for the same delta P. And then as you come down, you have in the middle somewhere, there'll be the best SATs, and they've got the best VQ matching. And then as you de-recruit and lose PEEP and get worse shunt the other way, then you get lower SATs. And the same is true for the compliance. So at the end, you have a best SATs and a best tidal volume. They're normally in roughly the same place, but not always exactly the same place. And you look at this chart and you go, well, for this patient, oxygenation is a bigger problem or compliance is a bigger problem, then you set the PEEP. So it's quite time consuming, as you can see, it's quite arduous. Have I explained it clearly? Do people understand why you do that? So that's a really scientific approach to what is the best PEEP. Whether it helps or not is not that clear, but it's clear if you do really high pressures, it's bad for you. So I think if you weren't sure, then it's a reasonable thing to try and do.
And how long have you got that best peak for normally? As in,
Yeah, a day,
a day,
or if you want to do it 12 hourly, you can. Yeah. So proning, much more straightforward, although has many associated risks. So we'll talk about it. So why might you prone someone? Well, it definitely improves your oxygenation and it probably improves your mortality. How does it do that? It probably improves your VQ matching. Everything's about VQ matching. It increases your expiratory lung volume, so it recruits up your lungs, and it decreases your lung injury by more uniform distribution. And so a picture that has been helpful for me to understand why. So this is when you're supine on. I can't show you. So on the left, you see where you're supine. You see like a curly spring, and it kind of bunches up around the bottom. When you put someone prone, because of the anatomy, essentially you get a more equal distribution of your lung units. So you more uniform alveolar size, optimised ventilation, decreased stress, so you get better VQ matching. It's recommended for patients with severe Ards for at least 12 hours a day. There aren't hard and fast criteria about when should you do it. It's meant to work well for COVID. We're already doing it with one patient at the moment. I think it's going to be a consultant decision. There's no specific rules. The main risk is clearly dislodging tubes and lines and stuff. The main one is if the ET tube is displaced, particularly if they've got refractory hypoxemia and they're prone and the tube falls out, and it's going to be hazardous, to say the least. And you've seen there's a proning drill, and there's a video, and I think that's being updated today. So that's all I'm going to say about proning. I'll mention ECMO briefly. So at the moment, there are patients getting ECMO for COVID pneumonitis. I mean, as this pandemic takes off, I'm sure that will change, and they probably will stop delivering ECMO. But at the moment they do it, and they haven't changed their referral guidelines. So if we have a patient who's suitable for escalation, and we're really struggling, refractory hypoxemia, if you just Google GSTT ECMO referral criteria, you get this page up on the right, and it tells you who they want to know about. So essentially it's people who I've just described who haven't been ventilated for a long time and are young and kind of fit, and then they'll consider it depending on their resource. What they'll often do is they'll come here with their special ambulance full of gear, and they will have told you to look up also on their website a whole list of stuff you need to get ready, because they find it easier to establish one ECMO in theatres here and then take them back to St Thomas's. So they'll probably do that. We'll talk about it very briefly. These are both venous ECMO. There are two ways of doing it. You can suck the blood out from their tubes in the legs, and then pump it through the oxygenator and then back in through the right internal jugular, or you can have this dual lumen cannula called the Avalon cannula that you can see there, takes it from the IVC and the SVC and pumps it into the tricuspid valve. So they tend to go for more of the separate tubes, like on the left, rather than the combined one. So the last, go on.
Do you know what sort of demographic they're currently taking? Presumably their threshold is a bit higher with problem to take patients.
They haven't given any guidance, so I don't know how they're adjusting, but it's a heavily intensive resource, and if we're running out of critical care resources, I'm sure they'll do less and less. Maybe they won't stop altogether, but they'll probably do less and less. So APRV is a mode of ventilation that people use for refractory hypoxemia. We don't use it a lot on this unit at the moment, but we might need to look into it. Some units use it all the time. Has anyone used it? What it is it's a mode of pressure control where you have the patient breathes independently on top of some mandatory ventilation. And basically you set the pressure high, and they have tiny little fractions of time where the pressure drops low, and that's when they breathe out. So it looks very different. The pressure waveform I've got here. So this is the normal one. So the red is the pressure applied by the ventilator. So you go from your PEEP to your inspiratory pressure, and then back down again. So it's completely different in APRV. So if you look on the bottom right, the red line is at the top, and so you spend most of your time at a high pressure, and you have a fraction of a second, 0.2 to 0.6 of a second, where you breathe out. So you don't finish breathing out. You see the orange line is the tracheal pressure, or the alveolar pressure. So it starts to drop, and before you get anywhere close to the PEEP of 0, you get your next breath in. So it uses auto PEEP to maintain a higher mean airway pressure. So the green dotted line on the left, you can see the mean airway pressure, which I told you is the main determinant of oxygenation, isn't very high in a traditional way, but in an APRV, it works through keeping the mean airway pressure very, very high. And this doesn't show spontaneous breathing, but it works best if there's a little bit of spontaneous breathing all the way through over the top of that waveform. There have been lots of little studies, so lots of ongoing trials. There was a meta-analysis published last year that showed improved mortality and certainly improved oxygenation without differences in rescue therapies or barotrauma. But I say there's a problem with it. If you have lots of small studies, mostly single centre, you get reporting bias and things like that. So there's not strong evidence, and therefore it's not in any international guidelines, unlike proning. So you can increase lung recruitment, as you can imagine. It can reduce atelectasis, or the trauma of repeated atelectasis being induced. You can improve your VQ matching. They say lower sedation, neuromuscular blockade requirements and hemodynamic benefits. I'm not sure. Possibly improve mortality. But the cons are, you've got a really high airway pressure all the time, so you cause barotrauma, volume trauma. Definitely get decreased venous return for the same reason when you're doing recruitment, you get decreased venous return. It can be uncomfortable. It can look uncomfortable, as you can imagine. If they're breathing at 30 centimetres of water on top of that, it looks a bit weird. You can get dynamic hyperinflation. The main thing here is lack of familiarity. So if you're cool to see someone on the unit who's on APRV and they're hypoxic or hypercapnic, it's difficult if you're not used to it. It's not as if it's a normal ventilator, you know exactly what to do. But if you're ventilating this slightly weird way, it's not so clear what you do straight away. But we could fix that. So when would you use it? Refractory hypoxemia that's better at higher airway pressures. It works well if they're spontaneously breathing as well, and it can be combined with prone positions. So we might find ourselves proning people and on APRV, particularly if ECMO has been taken away as an option. They're very hypoxic. Why wouldn't you try it? So how to use it? How to do it with our ventilators? So this is not done on a patient. This is just me playing with a ventilator with a test lung. So this is an example of sort of standard lung protective ventilation before you start taking into APRV. So you can see they've got tidal volume of 400 odd mils. They've got a 1-to-1 IE ratio, and that's kind of normal ventilator. You've got pressure, flow, and tidal volumes. So the first thing to do is you're going to press the button to change the mode of ventilation, bottom left, and then top right there it says bi-level. So you're going to go into a bi-level ventilation. So these modes of ventilation, they don't have an APRV mode, but APRV is basically just two pressure levels with a very extreme inverse ratio. So you can make it into APRV. So you have a not very high frequency, and then you start by lengthening the inspiratory time, and the ventilator says, hang on, you've got very high inspiratory time, so it alarms. You persevere, push on through, and you keep lengthening the inspiratory time, so that's the time that's high, T high, and you can see here, if you've got 10 breaths a minute, you've got 6 seconds, and at the moment it's only giving 4.8 seconds, so it's not letting me sort of give me another alarm. So you keep pushing forward until you've got a really short, so you've got 5.5 seconds of your 6 seconds of your breath is during inspiration, so you've got half a second to breathe out. So that's where you might start. This is sort of beginner settings of most of the time at high, just 10 times a minute you drop to 0 peaks, you have a 0 level. It doesn't get to 0. So if you were to make that work on the test lung, what you see is most of the time high and then you drop down to 0. And this is too long in the test lung. You can see the flow, this is the expiratory flow, goes right pretty much back down to 0 before the next breath comes in. You don't want that. You want it to be breathing out but not finished breathing out before the next breath comes on. So with this test lung, if you drop the pressure down to 0.2, so that it's breathing out but it hasn't finished breathing out before the next breath comes, you want it more like that. And I think I've got in the WhatsApp group, there's in the BMJ education this month, there's a section on APRV, and this is a picture taken from it. They obviously showed a different type of ventilator, but it's the same idea. It's a bit complicated, but essentially you want the expiratory flow to get to about 75% of the maximum before the next breath. But as long as it doesn't completely empty before the next breath, that's what you really want. So you can see it's a bit fiddly and it's a bit unfamiliar. So now we're going to go through, so say someone's on APRV and some things that might go wrong. So they might be hypoxic. So you could try to increase the FI2, or you can try to increase the mean airway pressure. The two ways to increase the mean airway pressure is to push the pressure high up and to give them less time breathing out. If they're hypercapnic, then you want to increase the tidal volume in the same way as you would in a normal mode of ventilation, but it's a different way how you might do it. So you might try and get them to breathe on top of it. That makes it work much better. You might try turning up the P high. You might try fitting with how long they spend at a high level. So you might give them longer, you might give them less. So basically you have to fiddle with it for that. But what I would do is I would try and increase the frequency of the release. So you can change the ventilator frequency from 10 to 12, whatever, and then I'd look at how their tidal volume during that release and perhaps lengthen the expiratory time so they breathe out more. Hypocapnia is rarely a problem. It means they're ready to move on. So I'm going to summarise and say that lung pressure ventilation is really quite straightforward, and that's the mainstay of 99% of what we're going to do. Don't routinely use neuromuscular blockers, but if you're called someone who's dysynchronous, it fixes it quickly, as long as they're sedated. Staircase script maneuver decremental peak trial isn't routine, and it can be helpful, but it can break people as well, so I'd be careful. Proning, we're going to do quite a lot of. It's safe, but it does require a lot of care with the tube. ECMO is a good option while it's available, only for really refractory cases. APRV is of unknown effectiveness, and it's very complicated. It's not straightforward to troubleshoot. I'm going to be around as much as I need to be to help people with refractory hypoxemia, and that's it. Any questions? Does APRV seem very weird, or?
Seems unfamiliar. I'm
Yeah.
not used to it, but
Have you used it,
I can see
Barbara?
how it works.
Yeah,
Do you like it?
I mean for the refractory ones, it does make a difference. So you see the oxygenation improves as you think